So good evening, everyone, and welcome to this webinar today. And it's my pleasure. I'm Dr. Priscilla Rupali. I'm a professor of infectious diseases, and I work at Christian Medical College, Vellore. So Christian Medical College, Vellore is collaborating with the One Health Trust to bring about a policy brief on vaccines against AMR. And these webinars are being conducted as a result of that. And I will hand over in a few minutes to Dr. Urta Kalanji, who will take us further through a few directives from GARP. It's my pleasure to welcome all of you to this webinar, and it's wonderful to see so many of you online. A special welcome to our guest, Dr. Jacob John, a very dear colleague and friend, and as all of you know, has published extensively on typhoid. For those of you who are interested in typhoid, he's was the mover and shaker behind the CEFI cohort of typhoid, which mapped the burden of typhoid disease in India. Very recently, he has been the principal investigator of the VVAC trial, where he's trying to measure the impact of typhoid vaccination in the community. So I won't take too much of your time, and it's wonderful to see you all online. And I will now hand over to Dr. Urta Kalanchi, and she will take you through GARP and its mandate and its remit. Over to you, Urta.
Thank you very much for that introduction. Very nice to see some familiar names over here. And thank you for gathering us today, Dr. Rupali. So my name is Urta Kalanji. I'm a research fellow and director of partnerships at One Health Trust. And as Dr. Rupali mentioned, we are collaborating, One Health Trust and CMC Vellore are collaborating within the global Antibiotic Resistance Partnership Project. As we call it, GARP. It's a network of experts across various countries in Africa and Asia. And these experts are infectious disease specialists, AMR specialists, immunization scientists, and policymakers. So it's a really diverse group of experts from various countries who come together to discuss, bring forth evidence that connects vaccines with antimicrobial resistance. So very briefly, these groups are not new. They have been around for a while in many countries. At the beginning, which was over a decade ago, they were working hard to bring awareness to antimicrobial resistance, and they delivered they developed several publications that summarize the burden of AMR and antibiotic use in both animal and human health in various countries. Today, GARP experts are together to really evaluate the impact that vaccination has on addressing AMR. So vaccination is a very powerful tool because it prevents infections in the first place, and it reduces not only the spread of infectious diseases that carry high AMR rates, but also it reduces the need for treatment with antibiotics. So there are several drivers of AMR that are being addressed by vaccination. Now, this is pretty obvious to some, but this has not been quantified before. So in recent years, there have been publications from our group and collaborators showing that really vaccines are a very powerful tool to address AMR, and they quantify the actual impact in terms of health and economic burden in some cases. I'm very excited to be here today. I won't take any more time. Very excited to listen to Dr. Jacob's presentation. The typhoid Typhoid fever and the typhoid vaccine are excellent examples that really show what happens over time when antibiotics lose their effectiveness, and how important vaccination is, not only to really minimize the development of resistance, but also to control outbreaks in real life. So I am going to stop here. Thank you, and over to you, Dr. Jacob.
So thank you, Atta, for that. And now I'll hand over to Dr. Prasanna Kumar to introduce Dr. Jacob John.
It's my pleasure to introduce Dr. Jacob John. Sir is the professor in community medicine at Christian Medical College, Vellore, and he's also the head of the newly found School of Public Health, CMC Vellore. His research centers on epidemiology and infectious disease, particularly on typhoid and its vaccination. His current research focused on estimating the burden of typhoid in India, and he oversees the Vellore Typhoid Vaccine Impact Trial. And he is also a member of various government technical advisory groups, including epidemiology and vaccinology, and working group of typhoid and cholera of vaccination and immunization. And he's also a member and scientific advisory committee of Institute of Epidemiology. And there are various bodies he's member of it. And he's also the vice principal of research at Christian Medical College, Vellore. Thank you, sir. Thank you for accepting our invitation.
Thank you, Prasanna. Thank you for those kind words. And I'm really grateful to Priscilla and Atta for giving me this opportunity to be here and to share some of the thoughts we had around AMR. Can I just see if I can share this in a moment? Yes. Are you able to see my slides?
Yes, sir.
Great. So just as a disclosure, these are just my thoughts, and they don't necessarily represent the thoughts of the INTAGI or any other group that we've been working with. But it's really a pleasure to see all of you on this call, because a lot of you are long-term collaborators and people who worked in this space. So I am grateful to all of you for this opportunity, as well as this is really your work. And if you have some of these questions, I'll probably turn them back to some of the people in this audience, because you know more about what I'm talking about than I do. In any case, thank you again, and I will try to complete this talk within 30 minutes. And if I'm going over time, please stop me, Prasanna. So when we think about typhoid conjugate vaccines, they became a very important tool for us in the control of typhoid once they became available. Even before that, we had the polysaccharide vaccines, which were shown to be quite effective in the control of typhoid, but typhoid conjugate vaccines really changed the game for us. But before we look at typhoid conjugate vaccines, I think I'm just trying to set up a framework here for us to consider how we can look at typhoid. Firstly, we look at what is the impact of typhoid on the AMR problem. And we also talk about how can TCVs, typhoid conjugate vaccines, impact AMR. So slightly different questions. First is about typhoid and its impact on AMR, and then we go on to look at how conjugate vaccines can then impact. So in this, we will talk about, firstly, the direct impact of typhoid. How big is this problem in our region, in our country? How real is the threat of AMR and typhoid? We'll also look at the indirect effect of typhoid on AMR, especially in settings where it's difficult to diagnose and difficult to get investigations done prior to treating patients. And we will also talk about the impact of having these organisms in the environment and how gram-negative bacteria tend to share plasmids across both in the environment and in the host. We also then look briefly at how typhoid conjugate vaccines can impact AMR and work that we hope can be done in the future. I know there are colleagues from ICMR here, and there is a lot of effort going on at the moment to see how these strategies can be put in place, both for typhoid and for other priority bacterial organisms for AMR. Sorry. So we move on to first a very quick look at Salmonella typhi. I know that this is a heterogeneous group. So for those who are experts in the field, please feel free to tune off for the next couple of minutes. But Salmonella typhi is a highly conserved serovar of the genus Salmonella. It's fairly parsimonious phylogenetic trees, and it has actually been quite well preserved considering how long the organism has been with us. The good thing about Salmonella typhi is that it's a human host restricted organism, not found in the environment to replicate widely or in other hosts. The presence of Fimbriae and pseudogenes are important in this process of host specificity. We also know another thing about Salmonella typhi, like unlike other very reactogenic organisms, Salmonella typhi is actually a stealth operator. The initial infection hardly mounts an immune response, and it's part of the way it survives. So because of that, early diagnosis of typhoid using immune responses is difficult to achieve. More recently, we've learned about typhoid toxin, a chimeric A2B5 structured protein. While its role in virulence is not very clear, it appears that typhoid toxin may have a role in its persistence in the body, and its role also in causing disease is still being explored. Finally, I want to focus on the fact that Salmonella typhi freely receives and shares plasmids with other gram-negative organisms. And this is probably one of the very important reasons why control of typhoid is important for the control of AMR. Moving on to the diagnosis of typhoid, as you all know, typhoid is a difficult organism to grow in culture, primarily because the bacteremia is not of a very high load. You get about 1 CFU per ml. The sensitivity of blood culture, even in ideal situations, is about 60%. Bone marrow cultures do better, but are very difficult to perform except in ID settings in some of the tertiary care centers. Blood cultures are also sensitive to the receptor of prior antibiotics. So if you have a drug-sensitive strain of typhoid in the environment, and commonly used antibiotics often clear the infections before the blood cultures are done. Automated systems and the presence of resins in these bottles have mitigated this, and you're able to do blood cultures better. But as we all know, blood cultures are not point-of-care diagnostics and are often not performed. Stool culture is not a great tool for diagnosis of typhoid, but it can be used to look at shedding, and it can be ancillary in the diagnosis of typhoid. Moving on to the serological methods, Vidal was a very commonly used test, but in our settings in developing countries, it's got a poor specificity and sensitivity. We would need at least a couple of samples a few weeks apart for us to be able to say that there are rising titers which are much better at diagnosing typhoid. Similarly, we have other diagnostic tests, which are serological, Typhidot, Tubex, and so on, which held a lot of promise, but more recently have become discredited in settings because of the lack of specificity. VA antibodies, great to identify population level of exposures, but not very good at diagnosing typhoid. It may be useful when there are high titers of VA antibodies in detecting chronic carriers, but not really a diagnostic tool. More recently, there's been a lot of interest in the IgA assays against hemolysin E and LPS. It's very promising, but it's still a lateral flow test, which is not really point of care yet. And we need more data before it can be used as a diagnostic assay. So short answer here is that serological tests are there, but they are not very specific and often are not considered good tools for diagnosis. And unfortunately, a lot of people use them. And because of the lack of specificity, overtreat with antibiotics, people who commonly have viral illnesses. So now moving on to the first part of the larger problem. That's about the organism and its context. And now we look at typhoid as a problem. So globally, typhoid is seen as a significant problem with significant morbidity, with over 21 million cases anticipated each year. But secular trends suggest that deaths due to typhoid and hospitalization due to typhoid have been falling quite dramatically from the 1990s. What fuels this is not still very clear, but these 10 trends are unambiguous, with the greatest fall in the Pacific Islands as well as in India. But almost all countries have seen this decline in typhoid. This then led to a situation where in 2015-16, when the vaccines became available, people weren't sure whether typhoid is a problem. But then there was this question about what are the determinants of typhoid? Have the determinants of typhoid really changed? Unfortunately not. Safe water is still a distant mirage. So is sanitation. Unfortunately, with the ways our cities in India are planned, they're not really planned cities. We develop them, and as we develop civic society, facilities of sewage and water systems, they're very close to each other and more prone to contamination than even before. So what food hygiene, as you know, if you walk down the streets, it's improving, but it's not really gotten very better. So why is typhoid then coming down was a question. Perhaps improved economic situation and access to antibiotics may kind of give us an idea of what is happening. So is typhoid really hiding in the background, or is it something that's under-recognized because of the way we diagnose it? Typhoid is only diagnosed by blood culture or by confirmatory 2 samples of viral, and that obviously is not something that we are seeing very often. So we started with this question in 2017. Perhaps typhoid is going away, perhaps typhoid is not going away. And the reasons I mentioned before are because the risk factors for typhoid were just prevalent. So maybe our hypothesis then was the risk of transmission of typhoid hasn't changed, but with economic progress and access to healthcare, complications and hospitalization with typhoid has decreased. It may be that early and presumptive treatment with antibiotics in the community may be hiding the disease, which then might surge back when there is antimicrobial resistance happening. So it is on this premise, with the support from ICMR and the Bill and Melinda Gates Foundation, we set up the surveillance across 18 sites in the country, both urban and rural. We had 4 large cohorts of children and 18 hospitals across the country in tier 2 and tier 3 cities, many of you have been part of. And from that CEPHI surveillance, which is surveillance for enteric fever in India, we came up with estimates of typhoid in the country, which really looks like the map of the Earth, or the view of the Earth from the ISS at night, looking at where the population density is highest, there's a highest risk of typhoid. So looking at cohort studies that we did 4 cohort studies, one in Vellore, another one in Kolkata, one in Delhi, and one in Pune. 3 of these sites were urban, and the 4th site in Pune was a rural site. And what we learned from doing that surveillance, which is really about children between 1 year and 15 years of age, 6 months to 15 years of age, whenever they had a fever that lasted for over 3 days, we did a blood culture on them. And these rates are not extrapolations. They don't have any multipliers. These are just absolute rates of typhoid in the population. No adjustment for health-seeking behavior or anything else. What we saw, to our surprise, was that typhoid was just almost as high as what it was during Dr. M.K. Barnes' studies in Kalkaji, with rates of between 1,000 and 1,500 per 100,000 child years of observation, with the highest rates of typhoid in children under 9 years of age. And this was consistent across areas, though there was slight heterogeneity in the disease rates in different settings. But what you see, which is striking here, is what's different about the 3 sites which are urban. On the left side, you see Vellore, for instance, a map, and on the right side, Pune, a study area in Vadu. So where there is lower population density, typhoid was less of a problem. But what we also noticed that was in Pune, about 20% of children received, 12% of children received antibiotics before they received a blood culture. By day 3, they had all received antibiotics. This is despite our effort to avoid antibiotics in our cohort. Whereas in the other sites, the pooled average was about 4.5%. Just giving a hint that perhaps antibiotics also have a role in what's happening. Looking at a larger picture about children across just both the cohorts and the hospital-based surveillance that we did. We had hospital-based surveillance in several cities and in district headquarters across the country, in mission hospital networks, as well as in government hospitals. What we learned from here was typhoid is still very high. And when I say high, rates that are above 100 per 100,000 are considered high, and rates above 500 per 100,000 are considered as extremely high or very high. So we see that most of our centers are in the very high typhoid burden rates. And the sites that are in Raxol, for instance, is a unique site where we had very low typhoid. But in general, we found that typhoid is very common, more common in the densely populated urban areas and more common among children. What's also happened, and I just move on to, so I want to summarize here by saying that typhoid is a problem in India. It remains a problem, and this is data from just before COVID. And we've continued that surveillance, and we've continued to see typhoid. We've had over 1,000 cases of typhoid that we have isolates on at the moment, which Dr. Balaji and Jobin, who's on this call, are analyzing more carefully. We move on to looking at what happens with antimicrobial rates, with antimicrobial availability. And this is something to do with AMR. AMR is increasing, and this is something that's been a cat and mouse game for us from the beginning. So in the 1950s, we had serendipitous finding that chloramphenicol works against typhoid from typhus studies. And very soon, just in 2 years' time, we had the first reports of chloramphenicol resistance. By the 1970s, chloramphenicol resistance was widespread. But fortunately for us, ampicillin and cotrimoxazole became available, and we started using those more rapidly. And then we found in Mexico reports of multi-drug resistance, which is resistance against chloramphenicol, ampicillin, and cotrimoxazole. By 1980s, we knew that MDR was widespread. Soon we had H58 haplotype starting from the subcontinent and spreading across the globe. We then saw fluoroquinolone being introduced as a solution, quick defervescence, excellent drug to use, but it didn't take very long for fluoroquinolone resistance and non-susceptibility to emerge in the 1990s. And now we know that most, if not all of our isolates in India are fluoroquinolone resistant. So then we started using azithromycin, ceftriaxone, became recommendations for us in 2011. But if you look carefully, even in 2001, we had resistance reports on ceftriaxone. And in 2016, we tragically saw in Pakistan an XDR outbreak, which had both MDR as well as ceftriaxone resistance. Picking up AMR for typhoid seems to be a child's play. So if you look at this, what happened in Pakistan, chloramphenicol, ampicillin, cotrimoxazole, streptomycin, and fluoroquinolone resistant types emerged as what we call XDR in 2016. What really happened was that sensitive salmonella typhi first picked up the AMR genes on the INC1 plasmid, and it quickly integrated that into the chromosome and dropped that plasmid, because presence of plasmids seem to have a survival disadvantage. And soon it then picked up from E. coli another plasmid, which then converted with the XDR characteristics. So this didn't take very long, and unfortunately, even with all of this, very quickly became the dominance haplotype of typhoid in Pakistan. From about it took hardly a year for it to become 70 to 80% of the strains, and this also resulted in a lot of perforations and a lot of death at that point. And there was a rapid introduction of the typhoid conjugate vaccine in Pakistan, as we all know. So what we need in this scenario is population immunity as well as a safe environment. We need to work towards both and not think of vaccines as a panacea, but safe environments, as we all know, take a long time to get. What about Bangladesh, our other neighbor? And we see in Bangladesh that while ceftriaxone resistance has not been commonplace, azithromycin resistance has been reported by Sanjyoti and Huda from Dhaka. Between 2009 and 2016, there seems to be well-established trends of azithromycin resistance. And they've done a lot of work and shown that it just takes one amino acid to be replaced by glutamine or leucine from arginine at the 770th position for a drug-sensitive strain to become drug-resistant. Clearly, it doesn't take much for AMR to become a problem and to establish itself. I now borrow some slides from Jobin and Balaji, which actually looks at the trends of Salmonella typhi in South Asia. So we have three distinct types of H58 that are currently afloat in our country, and it varies from country to country. But what's important about all of this is they all carry multi-drug resistance of some kind. They may be different in their serotype, in their particular mutations, but however, they are all threats. And question is, we get a lot of people from Bangladesh coming to Vellore, and we see outbreaks in communities that are living here. It won't take very long for these strains to talk to each other and for the XDR kind of strains to come into work. So looking from our CEPHI-1 study, we've seen that there is a lot of genetic diversity with about 20 distinct genotypes of typhi in our cohort. This is a fairly busy slide, but just tells you that we have a whole lot of different types. And the north is quite distinctly different from the south in what we are seeing. But most importantly from this, I would like to highlight that almost 97% of our isolates are fluoroquinolone resistant, though most strains seem to be non-MDR in that only 2.5% of our isolates were MDR. We also noticed 2 cases of azithromycin resistance at that point in time in 2021. Looking at paratyphi, again, it's a similar story. We have 12 genotypes with the lineage ACNF. Regional differences exist, but fluoroquinolone resistance was very high. Fortunately for us, azithromycin and ceftriaxone resistance was not common at that point in time. There are more recently, and a lot of you have contributed to this information, we have been seeing ESBL positive typhoid fever in India. And this is something that's been increasingly concerning. We've had outbreaks largely in Gujarat initially, and then more recently we've had reports from Bangalore, from Hyderabad, and so on. So there are several strains that we know are now ceftriaxone resistant. And these are different mechanisms from what was seen in Pakistan. So picking up antimicrobial resistance seems to be something that we have to deal with typhoid. And once these organisms pick up multi-drug resistance, they are causing longer duration of fevers and are getting picked up more commonly in our hospitals. So I thank Dr. Bhavani, Dr. Geeti, and others who have provided this information. We continue to monitor this, and I know that ICMR and Dr. Kamini are also looking at this data very carefully. More recently, we've had reports of carbapenem-resistant typhoid in India, and these are also resistant to fluoroquinolones. The resistance mechanisms seem to be plasmid-mediated with X3 and FIPK plasmids being responsible. Some of these have been in Bangalore, but they had some people who picked it up in Bangalore, but we found them in Kerala and other places. The treatment options at the moment are azithromycin, and we're very concerned about what happens to azithromycin next. So to conclude that bit, we say typhoid transmission continues unfettered. Incidence in the community is high, but we don't largely see it because we don't do the test that we need to. Perhaps with antibiotics being commonly available over the counter, they are being treated well. But we are very worried about what happens when XDR starts to break out or the commonly used antibiotics don't work. And this is why the NTAGI looked very carefully at the burden of typhoid and the threat of AMR and made recommendations for the introduction of the typhoid vaccine in our country. So that's the direct impact of typhoid on AMR. The indirect impact of typhoid is much larger, actually, because a lot of us treat presumptively patients with febrile illness lasting for more than 3 days as typhoid and with antibiotics. Now, what this does is, while if these people carry the bacteria or as we call the bystander effect, is something that can happen, and the antibiotic pressure in the environment is probably likely to create more antimicrobial resistant strains of typhoid for us. So the use of antibiotics because of the suspicion of typhoid is another way in which typhoid contributes to AMR for gram-negative bacteria. The presence of these antimicrobial resistance plasmids, which can then be transferred to other organisms, is the other way in which typhoid contributes to AMR in the population. The slide on the right shows you that for every case of typhoid that is diagnosed, there are so many more cases that are suspected as typhoid and treated as typhoid with antibiotics. Moving on to typhoid conjugate vaccines, this is just a brief thing to say that typhoid conjugate vaccines have been kind of blockbuster drugs for us. The vaccine efficacy has been consistently above 80%, and the protection that typhoid conjugate vaccines seem to provide is between 8 to 10 years. There are concerns now from Bangladesh that in a high burden settings that you might need a second dose of the vaccine. Nonetheless, all the data that we have so far suggests that an extremely high effectiveness for this vaccine. There are 3 large studies that have been done. 2 of them have been individually randomized, and 1 was a cluster randomized study from Dhaka, all of which similarly suggest that typhoid conjugate vaccines work really well. So then I move on to say, how can typhoid conjugate vaccines help? Simply put, typhoid conjugate vaccines will then, because of the polyclonal antibodies that are created, as well as some amount of cellular immunity that results from these conjugate vaccines becoming available, creates an environment where you have people who are protected against the infection. And when they are protected from the infection and replication, they are then less susceptible to also contribute to the pathway of creation of AMR. So this is a cartoon from Francisca and Reno Repollo's group, which actually shows us the differences between how antibiotics would probably work in the context of AMR and vaccines. So vaccines are really looking at clearing the infection and not providing opportunities for the antibiotics to interface with the bacteria and for antimicrobial resistance to be created. On the other hand, treatment is always reactive, and if the presence of AMR can be much more of a problem. I move on to think about the indirect ways in which typhoid conjugate vaccines could help. And this is more speculative in that sense. But if you think about vaccines, they directly work on the individual, making them non-susceptible and therefore protecting them. And when they do that at scale, when a large proportion of the population is protected, they also hinder transmission of typhoid. And when they can stop the transmission of typhoid, they can also stop the transmission of drug-resistant typhoid. And this is the basis on which population-level immunization is being advocated. However, the jury is still out on this. I'll just briefly talk about this interesting study, which was supported by Gavi, done by Ginny Pitzer and her group, along with IVI, which was estimating the effect of vaccination on antimicrobial resistant typhoid in 73 different countries. And in this modeling exercise, what they noticed was if you introduce typhoid conjugate vaccines at 9 months and did a catch-up campaign to cover children under 15 years of age, you would be able to reduce the relative prevalence of AMR typhoid among all typhoid by about 16%. In addition, you would avoid about 42 million cases of typhoid, which are fluoroquinolone resistant, and 21.2 million cases of MDR typhoid over a 10-year period. This is consistent with our modeling data, which also suggests much larger impact on overall typhoid. This is just looking at what would happen to multi-drug resistant typhoid. Now, I just go on very quickly to say what we've been trying to do at Vellore to support the national policy on vaccination. We're doing a cluster randomized introduction of typhoid vaccines. In this study, we've taken Vellore city, which has a population of about 500,000. In that, we are taking an area, zone 2 and zone 3, which is about 200,000 people. In this we've identified 60 different clusters, 30 of which would receive the vaccine and 30 which would not receive a vaccine. And we mounted a surveillance system in that setting to look at the impact of large-scale introduction of typhoid vaccine. What we've also done is that we vaccinated children from 1 year of age all the way up to 30 years, adults of 30 years of age, to say what would be the impact of a wide age range vaccination on the impact on typhoid. In addition to looking for blood culture confirmed typhoid, we are also looking at environmental samples to look at sewage samples in about 44 locations across Vellore to see both how many typhoid we are able to pick up by PCR and also look at AMR genes in the environment. And this is an ongoing study. We are 15 months into the study. Just briefly about the study design, we first established a surveillance within the entire demographic surveillance system of about 100,000 people. 72,000 population was in the 1 to 30 year age group was selected for the study in 60 clusters, 30 of which received the vaccine and 30 did not receive the vaccine. We used the Typhoid from Biologically for the study, and we've been doing a lot of blood cultures. So what we've done so far is about 9,500 blood cultures over a 15-month period. And we do blood cultures on day 3 of fever, and we found 232 cases of typhoid. What you also notice here is that typhoid is not uniformly distributed over time. We see them in clusters, and when they happen in clusters, they cause a lot of anxiety in the population. But this pales in comparison with what happened in Pakistan when there's been a drug-resistant typhoid outbreak, or when H58 was introduced in Malawi and in Africa. So I want to pause here to say that typhoid is an important problem, but so are so many other priority pathogens. And unfortunately for us, we have vaccines for typhoid now, and we hope that the country will introduce it before it becomes a major public health problem for us. We also have vaccines for S. pneumonia and for pneumococcus and for H. influenza, which are already being used. Typhoid is here, and we hope that other organisms which are important for typhoid, for antimicrobial resistance, will also receive vaccines in the near future. And we thank all of you for your patient hearing. I'm ready for any questions that you might have. And I look forward to conversations that can help us try and prevent an AMR outbreak in our country. Thank you.
Thank you, Jacob, for that wonderful talk. There are a few questions in the chat, and while people are thinking of questions, maybe I'll just ask those questions to you. So the first question is, do we have any defined internationally accepted correlate of protection against typhoid? If yes, which antibody and what titers?
So that's a good question, because in terms of for vaccines, we don't have a correlate of protection. That's the first answer. But often what we use is VI as a correlate for vaccine development and immunogenicity for vaccines, but truly not a correlate of protection. And that's one of the challenges that we have had with typhoid so far.
Sure. So Jacob, there are a couple of questions about why is typhoid incidence different in different parts of the country? For example, Pune being having a less infection rate versus more infections towards Delhi and other areas. So is there a basis behind it? And if so, what? And I'd like Dr. Camilla, if she's online, to also pitch in after Jacob says something.
Sure. Thank you for that question. I'm sorry if I gave the impression that typhoid is very different in the regions, because that's not what it really is. It is our site in Pune, which had a low typhoid. And as I'm alluding in my slides, Pune was a rural site. It had a rural agrarian community that we were dealing with, whereas the other 3 sites were in urban, densely populated urban settings. What we have consistently seen is that it is not about whether it's a tier 1, tier 2 city, where the population density seems to be high and where sewage systems are not really very well established. In those settings, typhoid has been consistently found when we have looked for it. So it's really, if you look at the West, right now, the maximum number of typhoid that we are seeing from our surface surveillance part 2, which we just completed a few months back, is being from Gujarat. Baroda and Ahmedabad are places that we've been seeing a lot of typhoid from. So it's not the West has less. It's more that in the urban areas, we see much more than in rural areas. This is not to say that typhoid is not a problem in rural areas, because our definition of urban and rural is a bit difficult. Where there is population density, which is large, even if it's a biggish town in a rural area, you still see typhoid there. I'll stop here. And Dr. Kamala, if you're there, if you would like to add something.
Nothing really, Jacob. You spot on. I think it's just sanitation. It's looking at, and the more people, the more slums. And you were right. In Pune, you had a rural population. Rural will pick up, so that's why it was low. I don't think it's particularly better in Pune.
Yes, thank you, Dr. Kamila.
So,
yeah, go ahead, Jacob.
if I might just add one bit, if we have that time. Essentially, what we've noticed is in well-planned sanitation systems like in the West, we've seen where you have reticulated water systems where there is no chance for feces to mix with water. Typhoid and all other similar fecal-orally contaminated organisms actually disappeared over time, whether it was Philadelphia, whether it was Chicago. So we've seen that consistently happening. But what's different for us is three things. One is that we don't have good drainage systems, and even when we build them, we do not have the water channels that can be used well. So essentially, we live in a situation where we have severe shortage of water, and that's going to be exacerbated with climate change. In addition, we have not very well-planned cities, and sewage lines and water supply lines are an afterthought, and they usually come on the roads. So because there is very little space for these things to be well engineered, if you take a new city like Amravati, that will be different. But if you take cities that have already been built and you try to retrofit these systems, what we inadvertently do is bring our sewage channels very, very close to the water channels. And with intermittent water supply creating negative pressure systems, we have consistently seen typhoid being a big problem. I'll stop here. Thanks.
So, Jacob, there's also a question about what is the role of a carrier protein in the vaccines? And do you think a Salmonella typhi vaccine is better, or a Salmonella paratyphi, or something which has both?
So interesting questions again. I'll take the Salmonella typhi paratyphi question. For curious reasons that we do not know, the ratio of typhi to paratyphi in different places change over time. Part of that is speculated that the transmission dynamics of typhoid may be slightly different from that of paratyphoid. We don't really have good evidence for this. Paratyphoid is considered more foodborne, and typhi is considered a little more waterborne, but though both these mechanisms are equally important at play. Now, talking about typhoid is about 4 times as common as paratyphoid in most settings. In our settings, it's about 8 to 9 times more common. But this is not to say that paratyphoid is not important. As a clinical syndrome, we all recognize paratyphoid is very significant, and it's also picking up antimicrobial resistance very rapidly. And therefore, a bivalent vaccine with paratyphoid and typhoid is the way we think we go forward. There are several candidates currently being considered and developed. Some of them are quite advanced in their development. So we hope to see these bivalent vaccines coming in, and they are really important for us.
So, Jacob, there are a couple of questions about the number of doses that you think would be required for the typhoid conjugate vaccines. I think varying bodies give varying recommendations. So do you think 1 dose is enough? What did your study do? Did you give 1 or did you give 2? And what is your recommendation with regard to conjugate vaccines, 1 or 2?
Okay, so again, this is currently a hot topic, as you'd recognize, because what's happening is this recent data that's emerging out of Bangladesh and we would have seen these papers very recently, where they have done analysis of people who received typhoid conjugate vaccines as the initial component. And then when the MenC group, the control group, got those vaccines, and they compared the rates of typhoid between people who had received the typhoid vaccine earlier versus the people who received typhoid vaccine later. And they recognized that there is some amount of waning of immunity. Now, it's already difficult to get one dose of this vaccine in, and one dose we know protects. It protects for 5 to 6 years at least, and probably much longer. Now, where possible, yes, 2 doses. But when it's not possible to get the second dose, a single dose would be a great option. The one way I would think is pragmatic for countries to look at it is to start with the first dose and then accumulate evidence, because the second doses don't have to be given within a month or 2 months. It, in fact, seems to work best when it's given a year or two later. So it seems that with these typhoid conjugate vaccines, unlike many others where you need them in reasonable close proximity to each other, these can be actually given a little later as well. So that would be the way I would look at it. Countries, the danger with saying 2 doses of a vaccine for a country is, if you can't afford one dose, where are you going to afford 2 doses? And is that going to shut down the availability of a good solution? And in public health, we always have to choose between not the good and the best, but something pragmatic all the time. So I'll stop there. Sorry, take too long to answer questions.
No worries. Jacob, this relates to the CEPI study, really. So a lot of the patients are often given antibiotics empirically for treatment of enteric fever. So in your cohort, did you notice a lot of complications? Is it okay for us to wait for a diagnosis of typhoid before we treat empirically?
So in our cohorts, we always did blood cultures by day 4 or day 5. That's more because we were worried about people getting antibiotics a priori. But the answer to your question is, by day 3 of fever, you don't ordinarily see complications. We have not seen complications in that sense. We've seen a lot of dengue, which we pick up after day 4 or day 5 of fever, but not typhoid with complications. In fact, most of the typhoid that we have seen within 2 to 3 days of antibiotic therapy will become absolutely well. So we have seen no reason why we cannot defer antibiotics for up to day 4, day 5. But again, decision is always with the clinician. If you see a toxic patient, you're not going to necessarily wait for day 5. You do the blood culture on day 2, day 3, and you don't wait for a blood culture report and you can start an empiric antibiotic at that point if you have a very high suspicion of typhoid. So that's what we've been practicing. We've not tried to change practice very much. We are analyzing this, but this is an excellent question. We will look more carefully to see, is there more duration of fever or delayed effervescence in that group.
So Jacob, this is a question about the IDSP surveillance. So VVAC has been planned for introduction of typhoid vaccine. So depending on the NTAGI stand for implementation of the typhoid conjugate vaccine, do you think the IDSP surveillance would be enough to really see an impact of TCV?
So ideally, yes, IDSP should be, and we know that the quality of IDSP surveillance at the moment can improve. And there are things that need to be done before that's possible. And that's largely related to how we diagnose. IDSP can only diagnose typhoid if people do blood cultures or have a diagnostic test that is really good. And in the absence of good diagnostics, IDSP has to report both presumptive diagnosis as well as use other diagnostic tools. So in that context, I don't think if you want to measure impact, you will need a more sensitive tool, which is why I think the government is also establishing, I know the Ministry of Health is looking at establishing more surveillance in settings that we have not previously been involved with. So there is an ongoing effort supported by Gavi, which is looking at setting up surveillance in the northern states as well. So I think you will need sentinel surveillance ongoing. You cannot depend only on IDSP data to measure impact.
Jacob, there's a question about recurrent typhoid. So in your study, did you have people having more than one episode? And what happened to the VI antibodies in those people?
So we don't measure VI antibodies routinely. We have the serum samples on them, and we will be looking at that question. Recurrent typhoid is not as common as people think it is. In our cohorts, we have seen recurrent typhoid, so it's not that it doesn't happen. And fortunately for us, we've not had any most severe illness in a second episode of typhoid in the cohort that we have had. But you're all IDs physicians, you see a lot more of these recurrent typhoids than we do. But in our cohorts, no, it's not as big a problem as we think it is. People do pick up multiple infections. That's something that we are clear about, because if you look at, we've been doing population-based serology, looking at IgG antibodies against hemolysin and LPS across periods of time, and we see evidence of repeat infections. But that's infections and not necessarily clinical disease.
Sure. There's a question about carrier state. So what was the percentage of people who went on to develop a carrier state? And is it logical to demand that everybody is tested for a carrier state after they have finished treatment for typhoid?
So short answer, we did not test for carrier state in this. In these kind of surveillance, it's difficult to get them to come back multiple times. But again, in an endemic area where there is such a large force of infection, largely from convalescent cases, that is the primary driver in many of our settings. And that's very clear because we've done these studies looking at shedding in patients and shedding in household family members who are asymptomatic. And we find that parents pick up the infection and actually shed the bacteria in their fecal stool samples, but they are asymptomatic and they don't shed it for very long. Within 30 days, they are cleared. But having said that, I don't have the answer for you on what is the current percentage, but I know that Chris Parry has done some work on this in the past, and in the context of currently available antibiotics, that's a very small proportion of people who are chronic carriers, largely in the middle-aged adults.
So Jacob, a question is with the lack of adequate diagnostics, do we think that we're underestimating the burden of typhoid in LMICs? And there is a second question there. And would typhoid conjugate vaccine actually act as an outbreak control measures? And do we have any studies evaluating this?
There are two different questions there. One, the answer is absolutely yes. In the absence of diagnostics, we are clearly underestimating typhoid. This is something that's evident if you look at the unadjusted versus the adjusted estimates of typhoid in the papers that came out from the SEEP network in Bangladesh, Nepal, and Pakistan. You find that it's several fold higher just from the fact that we haven't tested people with febrile illness. But moving on to your next question, which is, there is clear evidence from Pakistan where in the context of XDR, there was a reactive rollout of typhoid conjugate vaccine. And the vaccine efficacy was about 90% in that population. And they largely controlled the outbreak using the conjugate vaccine. Meropenem worked, azithromycin worked in that area, but the control was really about the typhoid conjugate vaccine. So as an outbreak tool, TCVs can be used, but the problem is it takes a while for that to happen. And in the interim, they lost over several thousand people died as a result of the disease. So that's what you're worried about. Typhoid conjugate vaccines are not like ring immunization, which you can get results very quickly. It takes a while, and in the interim, we might have people who suffer.
So Jacob, just as an add-on, do you think we will see widespread vaccination rollout in India to control typhoid?
I hope so, but we have other vaccines in the pipeline. If HPV moves forward, I'm sure the typhoid will move too. I really pray and hope, and I know that some of you from ICMR are also here and the ministry, I hope that it will not take an XDR outbreak for us. And we have seen consistently XDR and carbapenem, but though it's not seen them as outbreaks. I hope that's not the trigger that we need for the vaccine to actually get introduced. It's been far too long from an NTAGI recommendation to a country rolling out the vaccine. The vaccines are available. We have newer products, bivalent products going to be coming out from Serum very shortly. So it's not, the supply is still an issue, but it's not as big an issue. Cost is something that the governments can consider. It is political will we need to start, and we need to start this soon. But I do understand the challenges post-COVID, where overall immunization coverage has been low. There have been other priorities for people. But yes, I hope 2026 will be when we'll see the typhoid vaccine in.
Jacob, are there any other vulnerable groups besides children who should be targeted by the vaccination campaign? I mean, traditionally we've concentrated on children, but isn't it time that we consider even adults as
Absolutely.
vulnerable groups?
So that's exactly what we're trying to focus on in this VIVAC trial that we're doing. We think vaccinating children alone is going to control the problem to a limited extent, but it's not really going to solve the problem, because what is now very clear is that these children and parents are actually part of this whole process of persisting transmission in the population. So not just from the question of vulnerability, but what we do see is above 40 years of age, we don't see much of clinical typhoid in most settings. So it makes sense that adults, at least those who have young children in the house, and when I say young, children under 15 years of age, those would be the population that I think need the vaccine. I mean, I don't have the evidence to support this, but this is just an opinion that I have. But yes, adult vaccination must be a part for herd immunity to even think of kicking in, because as we know, for herd immunity to work, you need a substantial part of the population at risk covered, not just the children covered. And this is the fallacy that many people have, that if the children, you have 90% coverage, you will see herd protection. No, not if adults are participating in the disease process. So since in many settings, adults have a lot of typhoid, we need to protect the adults as well. And they probably have a larger economic impact, because when the adults fall sick with typhoid, what we have noticed and previously published is that they are ill for a fairly long period of time, and then they're not able to get back to work because of the lethargy and everything else that is associated with this, that there's a considerable burden, especially in that age group.
So Jacob, there's a question about what kind of complications did you see in your cohort due to typhoid? The second
cohorts. So when we talk about the cohorts, we're talking about the children, and these were children who we did not see any significant complication in that cohort, right? But when you look at the largest surveillance that we did, which was the sentinel surveillance, we saw a fair amount. In fact, our case fatality rate was just under 1% of all the typhoid. And most of it was ileal perforation that we identified, though identifying ileal perforations to be attributable to typhoid is actually a challenge, because these ileal perforations happen a little distant to when you have bacteremia. So what we did was we tried PCRs, we also tried looking at antibody tests, and based on all of that and kind of a consensus diagnosis, we believe that a lot of the ones we saw were perforations. We've also seen cardiomyopathies. We've seen people with, Delhi had a few different and exotic presentations of typhoid, but in general, HUS was 1 or 2 cases, but that's about all we saw with typhoid.
So I think one of the last question here is, when do you recommend you give the vaccine after a patient has had an episode of typhoid?
So there are no, Priscilla, I'm not sure if there are any specific recommendations for when this should happen. So I leave it to you and Kamala to actually answer that question, because really there are no recommendations. There's no basis on which I can provide that recommendation.
Correct. So, I mean, traditional wisdom dictates we usually wait for about 6 months to a year because we think that there will be some amount of immunity that's existing, but we know that it doesn't, the immunity is not durable enough for us to not give them vaccine. So generally we wait for about a year in adults to give them the vaccine. And the other question was, what is the recommended duration of therapy to prevent carrier state? There are no recommendations as such for duration of therapy. I don't think it's directly related to carrier state. Jacob, if you want to come in here, but there are recommendations to treat the carrier state for a longer duration. So if you do develop a carrier state, then you give it for a longer period of time, usually 1 month. And if they settle with that, it's fine. Otherwise, you go ahead and do a cholecystectomy. That's the usual dictum. Jacob, if there's anything you want to add.
No, I think you're spot on, Priscilla. I mean, there's nothing more to add there. But I just like to just go back to one question that was asked about this controversy about the 2 doses versus 1 dose. And does it provide enough protection? If you look at the same time as what happened in Bangladesh, you look at what happened in Malawi, Malawi did not see this effect of waning immunity. So there is the hypothesis that when you have, and if you think about Bangladesh, if you look at the number of infections that a person has or exposures from the serological studies, each year people have about 10 to 15 episodes of infection. That's the projected rate. So that's a very, very high force of infection. And clearly, we know that immunity is not a all or none, yes or no binary kind of thing. So when you have a very high force of infection, reinfections are likely to happen. And what this also surprises us is that with this force of infection, why are people not developing immunity? So that's answers part of the other question about picking up an infection does not necessarily seem to protect against picking up another infection. Maybe it has an effect on the severity or symptomatic disease, but it is not something that seems to be truly protective. So coming back to your question, if one dose seems to work very well, so I would actually say that one dose is what we should go with at the moment, with the option of getting the second dose in high burden, high force of infection settings. So if you think about clinicians like us who are constantly exposed to typhoid, perhaps two doses may be worth looking at.
Jacob, through your Cephi study, did you have, I mean, you did measure correlates of immunity as well. Did you find there was I mean, we don't really have a true correlate. That's the basic problem. But did you have any rough estimates as to how long it lasted? Because I think there is a controversy as to exactly when to give the TCV vaccine after an episode of typhoid. And I see something in the chat about somebody saying 4 weeks. But how they got that data, I am not really certain.
So, in fact, because we have not been seeing repeated infections, repeated clinical disease with typhoid, the general conventional wisdom about waiting as long as you can before you give it makes a lot of sense. In fact, that is a population that is not the highest priority in terms of the vaccination. I would really think you need to focus on the others. Though there is a logic there, if you picked up typhoid once, you have some kind of a risk for picking up the typhoid, which may not be alleviated by your infection. So I get it, but it's not something that I can answer. I think I'd leave it to the ID community to figure this one out. But we do have the samples on all our patients. So if there's something that is a way we can analyze this more carefully, yes. Correlate of protection is the thing that we're all looking for. We think it will have to be a combination of antibodies, and it will unlikely be one. VI seems to be the one that people have looked at the level of the population, but right now the hot ones are IgA for hemolysin and LPS combined together. But we'll have to wait to see what pans out. We've seen serology for typhoid always giving us great promise and not delivering so far. So the jury is still out.
Sure. So, yeah, so I think there was a comment that in children, apparently it's recommended 4 weeks after the episode of typhoid. So I'm not aware of that. In adults, we don't do it. We wait for about 6 months usually before we actually give them the typhoid conjugate vaccine. So I think there is no data on which you can base this recommendation as far as I know, but I know Dr. Camilla and others are on a line as well. If there's anything, please do jump in. Okay, so we're about 8 minutes past our time. I would like to thank Jacob very much for accepting to speak. I think we're all dealing with AMR in different ways, whether it's with patients, during research, and we're all looking forward to, vaccines eliminating some of or mitigating some of these drug-resistant organisms. So thank you so much, Jacob, for giving us this talk, and we look forward to seeing all of you at our next webinar as well.
Thank you.
So thank you very much, and I'd like to take this opportunity to thank all of you for being here on behalf of CMC Vellore as well as GARP and the One Health Trust. So thank you all for coming, and good night.
Thank you.